So I'm really happy to be able to talk to you today. I do a lot of work in the health space, and I'm really obsessed with health. Healthcare, I like healthcare, okay. I buy it, I use it, I pay for it like everybody else. But there's really no inherent value in healthcare except to the extent that it actually improves health. And what I want to talk to you about today are different ways to spend our money on improving health outcomes. And policy and law is a big part of that. Also, for the medical community, your ability to understand your patients in their entirety and the other things outside the clinic that impact their health is really important to your being able to give the best care possible. This is the med school's disclaimer. This is the med school's objectives and the things that I hope to cover today. And now I'm actually going to get started. So this graph probably looks familiar to anybody who follows what's going on in healthcare. Our national health expenditures keep going up, and national health expenditures includes public, private, business, individual, all sorts of sources of expenses that relate to health and health care. And in 2023, almost 18% of GDP was consumed on health expenditures. It's expected to go up to over $7.5 trillion. It was $5 trillion in 23. And other high-income countries spend less than 10% of their GDP on health. And I'm okay with spending a lot of money on health. I'm good with if we could spend 20% of GDP on health, I would be really okay by that. But it would only be a good thing to do if we got the value for that kind of expenditure. And most of what I want to talk to you about today is how to get value out of healthcare expenditures. So here's what's going on. This chart goes back to 1960, and it compares a bunch of different Western developed countries. And the statistic they're using here is life expectancy. And what you can see is the red line is the U.S., the various shades of green are all these other countries. We've never been that great when it comes to life expectancy. But if you see what's going on in the last decade or so, it's not just that we're at the bottom, we're falling off. Our life expectancy is declining while others, maybe some have plateaued, but nobody else is declining the way we are. And it's not just in life expectancy. We have, should I stand back or am I too? Okay. Can y'all hear me? Okay. We have increasing and the worst infant and maternal mortality rates. And we also have an increasing amount of comorbidities where people have more than one thing going on with them, particularly with chronic conditions. So the equation at the bottom is really what I want to focus on today. And frankly, what I think all of our health and healthcare conversations need to be about. And that's value. How do we get value? And to me, and I think to economists, although I'm not one, value is the relationship between cost and quality. So if you buy a $5 t-shirt, it's probably not going to last through many, many washes. If you buy a $100 garment, you expect it to last a while. And so that's the relationship between the quality of something you buy and the cost. And what we want is for them to equal each other. If we have a really expensive health system, then we ought to have really great quality outcomes. If we don't spend so much on it, then maybe it's like, okay, people aren't that healthy, but big deal. We don't really spend a lot, so can't complain. So to me, if you want to figure out how we ought to spend our health and healthcare dollars, you have to go back and look at what is it that actually determines health outcomes. And this is something that anyone who works in population health or public health has seen a million times before. It was developed by some people at the University of Wisconsin, and it underpins something called the County Health Rankings that Robert Wood Johnson Foundation has been compiling and publishing for quite a while now. What it tries to do is allocate to various causes the contribution that they make to health outcomes. And so if you see that the top is social and economic factors, you see all of the items under that, and you can imagine why income and community support and community safety would be really important factors to contributing to your health outcomes. Then you see health behaviors. You understand that smoking, diet and exercise, all of these things are really influential on your health outcomes, your health status, and the physical environment. If you live in an area with shoddy housing and a lot of pollution, your chances for a healthy life are not as good as people who live elsewhere. And while these percentages, people pass them different ways, nobody who does this kind of analysis ever puts medical care above 20%. And so if you compare these drivers to where we spend our money, so the column on the left is the same as the slide before, just put into a different format. The column on the right represents the $4.9 trillion in national health expenditures from 2023. And the size of the typeface is a relative representation of what percentage of that budget they take up. So hospitals account for about a third of all health spendings. And then after that is providers, and then it keeps on going down. We have lots of conversation about prescription drugs and how quickly they're rising, and all of that's true. And we ought to do something about it, but they account for only about 10% of the total health spend. So if you're really looking for the places where the big bucks are, pharma's, there's some pharma bros and it's easy to point a finger at them, but hospitals are where the big bucks are going. If you look at the very bottom, the little bitty red at 3.5% is public health. And that corresponds roughly to the health behaviors. It's what the public health sector does. They work on clean environments and healthy living and things like that. And you can see we only spent 3.5%. That's actually a bump, and it's part of the COVID bump. If you go back as long as they've been keeping this data, you see that it's generally hovering just under 3%. So we are not making investments in public health, which is what underpins everything else. Most of our money is going into health care. Okay, other countries do it differently. So this is a chart with spending patterns, social spending and health spending in other economically developed countries. And the bottom part of each bar, the green part, is the percentage of GDP that each of those countries spends on social spending. And that's the name that the OECD uses. And it includes things like family leave, early childhood supports, public health, things that are not medical care, but that impact how people actually live. The top part of each bar, the blue, is direct health spending. And when you look at these columns, what I see is that the U.S. is not an outlier in total spend. I mean, we're on the high side, but we're not the highest. But what's really different about us than every other country is the proportion. We are spending way more on health, which really translate to health care, 97% of it. And we're spending much less on all of these other health impacting factors of life. And outcomes are not the same. So this is life expectancy among these same countries. You see we're the worst. The background columns are the same ones. This is how we spend versus how others spend. Maternal mortality among these same countries, we're the worst. Infant mortality, same. Obesity rate, same. Overweight and obesity rate, same. It doesn't have to be this way. We built the system we have, and so we can change it. That doesn't mean it's easy to change, but it means it's not a naturally occurring phenomenon, and we can change it. So I want to spend a little bit of time talking about this slide. This was appeared in an article in Health Affairs 4, 5, 6 years ago by some public health people to help us think about the relationship between where you invest dollars and what the impact can be. And so if you look at the downstream part of this slide, what you see is that you're talking about providing clinical care. And it's really important. I don't mean to be dismissive if 20% of health outcomes are attributable to medical care. Medical care is really important. We all need it, or we will need it if we haven't needed it so far. But it's really pretty downstream. You're talking about a medical model that is generally one provider working with one patient at a time, and the tools they're using are the medical tools that they're learning across the other side of campus at the med schools. Really important, but kind of limited in the tools and the number of people at a time who can be impacted. So if you move upstream to the midstream level, you're still talking about individual impact, but here you start broadening what it is you're trying to do for individuals, and you're broadening the tools that are available to healthcare providers to actually address people's health outcomes. And so you see organizations increasingly screening their patients about non-medical needs that they may have. Are they food insecure? Are they housing insecure? Are they living in dangerous circumstances? What kinds of needs do they have that can impact their health but don't have anything to do with a clinic? But then we are seeing more and more healthcare organizations, including now, I'm proud to say, the clinic that UH Med School is managing, actually integrating programs, developing programs to address some of these non-medical factors that impact their patients. And so that means you're still working one-on-one or at the patient level, but you're bringing a lot more tools to the table that can help address a person's health outcome. You're not just looking at a medical model. So the most upstream strategies are where you really look across the entire community, where you look at things like what are we spending in health versus social spending, where you look at what is our education budget like, what is our environmental protection budget like, and you ask yourself whether or not there are ways to improve at the community level the conditions in which people live and grow and work and play so that they have a better shot at a healthy life in the first place. And the tools available there for those of you lawyers and aspiring lawyers here include law and policy. And this is why I'm in this work, because if we can change policies and laws so that they promote health impacting expenditures as opposed to just paying for care once people are sick, if they can get into the system, we'd have a better shot at organizing ourselves to be healthy. So I want to talk about well, let me go back here. So I'm going to talk a little bit about the work that's going on in downstream, because I really don't want to poo-poo it. There's some good work going on there, and it's trying to move work upstream. Mostly I'm going to talk about this midstream, and I'm going to do that because I keep going back to money, because money determines what people do, what institutions do, and if we change the way we spend money, that's how we'll change what it is we get for our dollars. So I'm going to spend a lot of time there because that's where the money is. The healthcare system has locked up all the money. And if we want some of that money to be used for other health opportunities, that's the money we have to tap into. There's not this other fund that we just haven't discovered that's going to come in and take care of all of the non-medical drivers or social determinants of health. Okay, so we have a hospital-centric healthcare system. We built it this way, and we used to say we really liked it this way. And it goes back a long time. I mean, the first hospitals in the country, I guess in the world, really were more like hospices. They were places people went to die, and they were generally set up by social service organizations, often religious orders, and they were there to relieve families of the burden of caring for someone who's dying when you can't really do anything about it. But then science and medicine progressed, and we actually had some medical tools to take care of people, and we went crazy for hospitals. The federal government started funding through the Hill-Burton Act lots and lots of hospital beds, and so we started building hospitals. As you can see from this chart, back in the 1960s, we weren't really spending much at all on healthcare. But as we go on, we're spending more in all of these areas. Okay. But you see the hospital line is going way up. Is this me or you? Okay. Um, So when we get to about the 1980s, people start going, oh my God, this thing is so expensive. What are we going to do to curtail these rapidly rising costs? And that's when I would say the modern cost cutting movement came about. It really was about costs. It was like, we're just paying too much. We can't afford to keep paying more. That health care expenditures grow faster than other economic indicators, and we just really can't keep up with that. But that's changing now. This is an old slide, but it's the best one I could find to show you the difference between doing work inside a hospital and outside a hospital. Over time, it's become clear that a lot of the things that we used to do in hospitals don't need to be done in hospitals. They can be done in outpatient settings, whether you're talking about a day surgery center or freestanding imaging centers. Lots of the work can be done safely, and in some cases more safely outside a hospital. Hospitals are kind of dangerous places. The best hospitals have a lot of infection. It's hard to control infection. And the less time anyone spends in the hospital, the better off they are, because the longer you're in the hospital, the more likely it is that something bad can happen to you. And not because they're not taking the best care they can, but because it's the nature of putting a bunch of sick people and a bunch of diseases all in a confined space. And so over time, hospitals have been moving more services out of their hospital proper and into outpatient settings. And that's a good thing for safety and for cost. Now, some of the hospitals have figured out that because they're hospitals, if they own these freestanding facilities, they can charge a facility fee the same way they could if they were actually performing these services in a hospital. And there's a big debate going on at the state level and in Washington about whether or not it's fair and appropriate and justified for hospitals to slap on an additional fee simply because they own the place that is doing the exact same service that could be performed by a non-hospital operator. But even the medical institutions are moving in the right direction. So I talked a little bit about delivery of services outside of hospitals. You're seeing a proliferation of all sorts of access to care outside of hospitals. Some of them aren't great. You have some issues with freestanding emergency rooms that people don't understand charge the way an emergency room charges, even though they can't actually provide those services. But we have urgent care centers. We have day surgery centers. We have imaging centers. We have lots and lots of opportunities to do things that we only used to do in hospitals. There's really good work going on reimagining what to do with EMS. I mean, historically, you call 911, it goes to EMS, the fire department in most communities, and they have two options. They can do nothing, or they can send an ambulance to take you to the hospital. Most people don't need nothing or an ambulance to go to the hospital. And so we're seeing new programs evolve where EMS is going out, essentially making house calls by telemedicine. There's a great program called Ethan in Houston. So by telemedicine, they'll go to the person who called 911, because you have to respond when somebody calls. That's part of our public safety net. But they will talk to the patient. They will try to figure out what's going on with them. If necessary, they will do a consult with an emergency medicine doctor by telemedicine and help the patient understand whether they really want to get in an ambulance and go to an emergency room right now, or whether there's something else that can be done, including scheduling an appointment for them at an outpatient facility and paying for the transportation to get them there. And in some places, paying for the outpatient visit. And we're seeing great success in programs like Ethan that say, let's help people get the care they need at the place they need it, with the quality they need, and at the cost they need, because an ambulance ride is really expensive. And to do that for someone who doesn't need it so that they can wait to be triaged in an emergency room that's overcrowded, not good for anybody. There are also lots of examples of bringing specialty care into primary care settings. So there's a national project called Project ECHO that essentially helps train doctors who maybe they're primary care doctors and they're dealing with people who are diabetics and they're trained to refer up to a specialist. And that's not always necessary. And so you have programs like Project Echo that will come in and sort of back up a provider who ought to be able to take care of the person, but isn't exactly sure they can do it. And they can use the knowledge of another doctor who has more expertise rather than just referring the patient, making them go get another appointment. There's a service called ConforMed, which was put together by a federally qualified health center. And what it does is it will have consults in the room while the primary care doctor is talking to the patient who thinks they might need a referral to a specialist. So the specialist gets on and they help determine whether or not a referral is even necessary. And the reason they do that is they determine that almost half of referrals to specialists really needed. And so the person gets to the specialist, you've had to go through the time, the money, et cetera, and specialists have long backlogs. And so we've just taken one of their spots for someone who didn't actually need it. And so we are increasingly trying to help our primary care providers first, not think everything's about referral, but second, make sure that they have the knowledge and the backing and are comfortable in being able to do the work of not referring patients up. And one of the great things about the U of H med school is the focus on primary care gives you a really wonderful opportunity to think about how you can make sure your students learn the most, that your residents learn the most, and that they really get comfortable relying on specialists when they need them, but really being able to take care of patients with chronic conditions so that they're not seeing a specialist all the time. Lastly, the expanded use of telemedicine, which I think we're like losing it in Medicare. I can't remember if we're about to lose it in Medicare. We had a lot of flexibilities during COVID, which were fantastic. There's some questions about when it's appropriate to use telehealth versus having a patient in person. There's some questions about what it really costs to deliver telehealth visits. But this is an opportunity to change the way care is delivered in ways that make sense for patients and in many cases for providers as well. Okay, now I'm going to talk about the midstream opportunities. And again, because that's where the money is. We're still talking about the healthcare system, but we're talking about getting the healthcare system to use more tools than just clinical tools. Okay, and the reason I keep going back to the money is because whoever is the payer drives what's being paid for. That's how everything happens. People, institutions, we all do what we're paid to do. And if you look at this chart, this shows you where the $4.9 trillion in national health expenditures come from. And you can see that most of it comes from health insurance. And of the health insurance, the three big pockets there are private insurance, Medicare, and Medicaid. And I'm going to talk a little bit about each of these. Let me start with Medicaid and Medicare opportunities. So first, there are Medicaid 1115 waivers. If you're not a health law person, you don't need to know anything about this. But if you are, all states have waivers, and that allows a state to do something different from the strict confines of the Medicaid program and Medicaid law, most of which was written in the 1960s. And so states use waivers for all different things. There are two really interesting waivers that are out there right now. One is in California, and they call it CalAIM. And what it is doing is looking holistically at people. It's screening them for non-medical needs, and then it's providing a lot of enhanced care management, meaning there's a person assigned to that person to figure out what do they need and how do we get it. They're also paying with Medicaid dollars some of the costs, limited costs for housing for a limited period of time. They are also paying for food, where food is the answer to someone's medical problem. And they're doing things like going into homes and apartments and remediating asthma triggers, and they're using Medicaid dollars for this. And they needed a waiver because Medicaid has a list of services. These aren't on the list. North Carolina Healthy Opportunities Pilot is really interesting. It's got 3 regions in the state, each of whom have this big bundle of money, and they have put together a healthcare delivery system that includes all these community-based organizations who are providing food or housing or transportation or working on interpersonal violence. And they get paid the same way doctors get paid for treating patients. Um, there's been talk lately, maybe I'll talk at the end about what of this we think is going to survive in this new administration. The Trump administration approved the North Carolina Healthy Opportunities Pilot. Then this is really wonky if you're a healthcare person. Get on board. Otherwise, gloss over and just understand that there are legal and policy opportunities. So the Medicaid program has a provision that allows or encourages Medicaid providers to provide non-medical services in lieu of traditional Medicaid services where it's appropriate and cost effective. And the reason for this provision is Medicaid has this list of services, and if something's not on the list, then you can't do it. Well, short of going in and revising the list, what this authority does is it allows states with federal permission to say, we're going to substitute out services because we think if we do this, it'll actually reduce the need for doing that. Texas has used this authority for quite some while to provide non-traditional services to behavioral health, people with behavioral health issues. And they do it because it makes sense. If you're talking about somebody who can either be institutionalized or get supports at home that aren't part of Medicaid, it's cheaper to do the to do the supports at home. The State Health and Human Services Commission has its own non-medical drivers of health action plan, and it specifically says we need to do ILOS. It needs legislative approval, at least in this state, and there have been 6 bills filed in this session calling for the use of ILOS in Medicaid beyond what's already there. We made some progress in 2023. The agency put out their action plan, and that's good because they basically have said, this stuff is real. We believe in it. We're going to drive programs that merge with this way of thinking about health and healthcare delivery. We also got a great bill passed in 2023 called HB 1575. And to me, the thing that was so great about it was that it says in its preamble that there are impacts on health way beyond clinical care. And that, for people who are just thinking doctor, 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 is a really big deal. And what it does, it applies to pregnant women in Medicaid. And it requires that they get screened for food, transportation, housing, and childcare needs. And then for those who screen positive with one or more needs, they get case management, meaning a person assigned to them who is going to help them figure out what the needs really are and how to get those needs met. No, it's not paying for the needs, but paying for the case management to get people where they need to be is really important because you're talking often about low income, very busy people, and handing them a piece of paper and saying, here's where you can go and get all of these services is not particularly effective. Lastly, it has now included community health workers and doulas as actual Medicaid providers. And that's really important, the doulas, because of all the issues around maternal mortality and morbidity. And there's a lot of research that shows that you have better outcomes when a doula is involved. And community health workers, this means they can get paid for doing the active case management. Medicare has all sorts of stuff going on in the Medicare Advantage plans. Those are private plans that about half of Medicare beneficiaries are on. And basically, they're paid an amount of money by the federal government, the plan is, and then they are supposed to take care of all of the needs of their members. And these kinds of services, you can imagine why they would have wanted to make these available to the Medicare population. You're talking about elderly people who are also often very frail. And so the idea is we can keep them at home and in their communities and out of the emergency room, out of hospitals and out of nursing homes, if we can provide these supports that are not medical, but that allow them to stay in their homes and communities. And these are some of the examples. In the employer-sponsored space, that's really the hardest. And the reason it's hard, well, there are a million reasons it's hard, but one of them is that it's extremely fragmented. If you're talking Medicare, there's one Medicare, the feds control it. If you're talking Medicaid, there are 51 Medicaids. Each state and DC and the feds jointly manage that. And so you could get your hands around that and you could figure out how do we move one or 51 forward. But if you're talking about private insurance, you're talking about more than 600,000 separate employers in Texas. And even when you're talking about a really large employer that has 20 or 30,000 people, you're talking about kind of a drop in the bucket compared to the large number of patients that need to be grouped together for it to really start to make sense. But one of the things that's going on there are price transparency initiatives. There's also a group called the Houston Business Coalition on Health, and they are doing a lot of work around building a smart network, trying to help employers, particularly large employers, contract differently with health insurance companies, and in many cases with the doubling down on primary care, where they have a primary care contract with a provider who really is aggressive about doing preventive care and making sure the patients don't advance to needing more care. And then lastly, you have an activist organization, a 501c4 called Texas Employers for Affordable Health Care, and they're very active at the legislature. Most of their work is focused on reducing the costs of health care. All of these efforts are aimed at reducing the cost of health care as opposed to improving the quality of health care. They're really good efforts, and I think we'll see more of the same. There are also a lot of new requirements for providers and payers that are driving change. I'm going to move through these quickly just so you know that they exist rather than spending a lot of time talking about them. So for physicians, you have rules at CMS, which means Medicare and Medicaid, and you have a Medicaid program for physicians in Texas that requires them to do some work in this area. Hospitals have CMS regulations. They have Joint Commission, which is an accrediting body, and Texas Medicaid. Health plans, there are national standards and reports on health plans and how good a job they do. And they now are requiring their plans to report some things around this kind of work. And also we have HB 1575, which I talked about before, the CHWs and doulas. That law actually applies to the health plans. They can delegate that work, but they're the ones with the legal responsibility. And there are others who are impacted. The Joint Commission accredits lots of things besides hospitals, including ambulatory surgery centers, behavioral health centers, and they are also subject to that. 1575 covers another program called Thriving Texas Families. And the Medicaid rules also in Texas apply to our community health centers and to rural health programs that are participating within certain Medicaid programs in Texas. I'm not going to spend any time talking about upstream opportunities. Not because they're not like the most important, but because I think I'm going to exceed my time if I do that. There is a lot of work going on there. You've probably heard about the Accountable Health Communities program. It was a national program implemented during the first Trump administration that tested out different ways of engaging patients around their non-medical needs, and in some cases actually navigating them to get services. There is in Texas something called TACHI, which is the Texas Accountable Communities for Health Initiative, and there are, I think, 6 communities participating in it. There are wellness funds. There are a lot of ways that communities are coming together to figure out how do we solve this problem that crosses over multiple sectors. And there's some really exciting work going on in this space. Uh-oh. Signing in on another device. I'll just allow it. But it stopped my slides. Oh, there we go. Okay, you can be part of the change. So there's a new consortium in Texas called the Texas Consortium for the Non-Medical Drivers of Health. And it's something that we operate out of the Baker Institute at Rice. And its purpose is to actually build a field of practice to bring together the researchers, the practitioners, and the policymakers who are interested in this kind of work to look at how we support each other, advance the field, and from my perspective, change the policy environment so that it's easier to do this work and get paid for it. One of our really neat features is our program index, and this is all online, and the links are in the slides, which I think you'll all be given. We are cataloging programs that healthcare providers across the state are doing where they actually integrate some non-medical services, some programming into their healthcare delivery. And we have, well, this is an old slide. I think we've got 150 something programs in there as of today, and you can learn a little bit about them. And the point of pulling it together was, since it's only becoming a field of practice now, nobody knew what was going on. The state agency would call us and say, so who's doing what in this area? And I'm like, don't you know? I mean, you run Medicaid. And their answer was, yeah, we kind of don't really know. So this is helping the state figure out who's doing what. U of H, I saw a news article last week that you actually have a medical legal partnership now. So a medical legal partnership integrates a lawyer into the care team. In best case scenario, they're actually on site the same way you do with a social worker, behavioral health specialist, all of these other people whose unique knowledge contributes to helping your patients. And in the case of the medical legal partnerships, they look for people who have health impact, there's an acronym for it that I'm not even going to remember. But anyway, my favorite example of it are people who, a couple in Austin who had a child who was covered with bug bites, and they kept coming into the clinic repeatedly. And it's like, the bug bites aren't that big a deal, but why do you have bug bites all the time? Well, it turns out they had the air conditioning in their apartment was gone, and there weren't screens, and they were afraid to talk to the landlord because one member of the household was not documented, and they were afraid of causing trouble. And so the lawyer got involved, reached out to the landlord, got the family out of the house, out of the apartment, and somewhere else. And it was that simple, and she quit getting eaten alive by bugs. You can learn a lot more about this. The Texas Consortium is a great resource. There's also a group called SIREN, which is an acronym. It's at University of California, San Francisco, and they have cataloged the research nationally on the integration of non-medical services into the healthcare system, and it's just a fantastic resource. And then there's a group that works on federal policy called the National Alliance to Impact the Social Determinants of Health. You can follow these bills that are pending now. Mostly, though, you can keep in your mind that health is the outcome we're going for. We know what the drivers of health are. We have enough money to do it right. We just have to decide that's what we want to do. And moving upstream is one way to make quality and cost align. Thank you. Questions or?
Okay, so we'll turn to the Q&A portion. If please raise your hand. I'll bring the mic over to you.
Clear as mud.
Kind of just a general question on the possible outlook in terms of like the new administration and the kind of traditional health skeptics of how this will with communities, midstream and upstream funding programs, or if we're going to see a decrease in funding towards the traditional downstream programs.
So I've like two different, I'm glad you asked because I meant to address that at the end. So I've two conflicting answers to that. We are going to see cuts if the House budget resolution, which calls for $880 billion in cuts, from the Energy and Commerce Committee, and most people think the only place that can come from is Medicaid. We will see Medicaid cuts, and how that happens, there's a litany of ways it could happen. And if that happens, you will be cutting traditional healthcare benefits plus the funds that support doing these innovations within Medicaid. All that being said, and considering RFK Jr., so one thing about him is his focus on food and lifestyle and and environmental contamination. And so I am hopeful that he will see things like food as medicine, which is the national movement that sort of the umbrella for all of these programs that address food, that he will see those as better investments than paying for when people actually end up in a hospital. The Trump administration recently pulled back two pieces of guidance that the Biden administration had put out on this topic, but they left the one that their own people put out when they were there. And so I'm thinking that's part of their anything Biden did, we're just getting rid of, as opposed to a deep look at what's actually going on and what should we be doing. So cuts are going to impact everybody and everything, but there's some hope that Kennedy's focus on non-medical, aside from vaccines and stuff like that, will actually help drive some more expenditures into these things that actually prevent chronic diseases and help manage them better than just medical care.
Hello. Thank you so much for your talk. It was wonderful. I have more the stateside question of that. Obviously, we're in the middle of the legislative session and all kinds of exciting things are happening. It feels like every day. And I was wondering if you had a sense of whether Texas has an appetite for being more innovative in this space and the way we approach these non-medical determinants of health.
Texas has been really innovative when it wants to be, and I guess my take on it, it depends on the population being impacted. The reason we got 1575 last time was because there was such a focus on pregnant women. We lost abortion, and the outcomes data for pregnant maternal mortality were really bad. And so it was, let's do some things for women. That's how we got it, not because they said, wow, we could really be doing some social determinant stuff. And the ones that are up right now will only get through if they are viewed at better ways to spend money. And so that's how I talk about it, because I think of this as a better way to spend money. We'll see what gets through the bill. There are a couple of bills that are sort of omnibus that just says use the in lieu of services authority in Medicaid. Direct the agency to do that and tell them to figure out, which kinds of people and services and conditions to do it for. And then there are a couple of others that are more prescriptive, particularly around food as medicine. There's a good food as medicine bill that's pretty comprehensive and talks about different kinds of FIM programs that are available and the populations that could be benefited. But there's a bill in the House and the Senate, and in the Senate, it's from the health chair that say they want to do ILOS for nutrition, but only for counseling, not for actually giving people food. And so that might get there. And the reason they don't want to give people food is they say, well, they have SNAP and WIC. And so we're now going behind the scenes to try to say, this is not the same as SNAP and WIC. This is a medically tailored meal. There's a particular configuration of food that is given to someone because they have a particular medical condition, not because they're food insecure. And we've sort of muddled the food insecure from particular nutrients that actually have data to support that they impact particular health conditions. So hopefully some of that will get unraveled so that they don't, if they pass the bill, it'd be better than nothing, but it would be like this big a step, because you're talking about people who, if you give them nutrition counseling, that's great. Maybe they don't know, but if they don't have the means to acquire the food or the exercise, whatever it is, then just telling them that is not going to solve the problem.
Okay, I have two questions. One is kind of light. I just want to know, first of all, what sparked your interest into health law? And then secondly, generally speaking, California is looked at as known as more healthy for United States. And I was wondering your thoughts on if they do have any regulatory or social lifestyle things you think Texas could adopt.
They have a lot, but that's because they spend a lot. Their waiver is pretty pricey, and they are putting up their own part of it. They are willing to cover and pay the state share for a lot more people and a lot more services than Texas is willing to pay. The way Medicaid works is that there's a basic set of services and people that are entitled to be in Medicaid in every state. Most states build on top of that. Texas is really not built on top of that. And so some of the innovation you see is because states have said, we're willing to put more money in, and then the feds will match them and they get to do some more innovative stuff. We're trying to do innovation in one of the thinnest programs in the country. And so that just makes it harder. And your question about health law, I'm not interested in health law. I'm interested in health policy. And I'm interested in health policy because I think everybody is entitled to live their healthiest life, and we do not spend our dollars in a way that reflects that. And that's true whether you are very wealthy, very poor, although if you're very wealthy, you can afford to spend these other things, dollars on these other things, while if you're low income, you can't. And I feel like we're wasting money and letting people get sick and need medical services that they wouldn't need until a much later stage in their life. I mean, doing this stuff, it's not like if we all did this, we would all live forever. The point is not to live forever. It's to live to, at least your average expected lifespan, and to live healthy and able to live your life while you're having those extra years.
Hi, so just to follow up on your answer to that question, do you think there's anywhere, I'm curious about those outcomes that you mentioned early on in the slides. Is there any part of the US or any demographic or state perhaps in which we're actually doing a good job, meaning someone in Milwaukee is at least doing as well as the average person in Italy for the outcomes that you described early on?
That's a really good question. And the county health rankings is kind of supposed to give you that information, but it's presented in a way that makes it easy to compare within a state, but hard to compare state to state. I mean, I don't think there's any state that I'd say, they've knocked it out of the ballpark on every facet. I think that California and a couple of other states have actually done a much better job on maternal morbidity and mortality, but that's because they decided to pay attention to it. And I think the same is true elsewhere, but there's not, it's even of the more progressive states in North Carolina doing this Healthy Opportunities program, there's no one that's figured it out. And I think the reason for that is we live within a system that is still hospital centric, and that's where the funds primarily go. And we're talking about how we change that at the edges.
So one question I have is that some people that are in this space worry about the so-called medicalization of the social services sector. So as you noted, so much of the dollars, right, are in the healthcare sector. And this is about diverting some of the money that's being spent on clinical care further upstream, whether it's midstream or, as you said, really upstream. But there's a concern that when you start having the money come from the healthcare sector to the social services sector, so those that work with low-income housing, those that work with food insecurity, but now they're kind of beholden to the healthcare sector and they lose some of their independence and the identity that they previously had. So I'm just curious if you hear people talk about that and what's your own feeling about that?
Oh, I have kind of a harsh feeling about that. Poor CBOs. If we're going to use healthcare dollars, they come with strings attached. CBOs aren't used to having those kinds of strings attached. And if they want to, I hear this from groups in California who are trying to become providers and Medicaid, oh, we have to fill out all these forms. It's like, that's how it works. And so if you want the Medicaid dollars or the Medicare dollars, you have to play by the rules in those programs. The rules are always more cumbersome than they ought to be. But if you want to take those dollars that have traditionally been for medical care, you got to play within the system. I don't worry about medicalizing all of that other stuff. I just want to get the medical dollars over there. And in terms of, sometimes I hear, oh, well, we're, just a small nonprofit and we shouldn't have to do this stuff. If there's money for this stuff, somebody will come in and do it effectively and efficiently. There are already lots of providers they're all sorts of for-profit transportation providers and food providers because there's money for that in the Medicare program. And where there is money, there will be high-functioning public or nonprofit private organizations to do the work. The CBOs exist because government is leaving some things undone. Once government is paying for something, business swoops in.
Okay, great. Does anyone have any additional questions? Oh, one more.
I have more of a political question. So if I was a politician and I wanted to, I want quick fixes so that I can tell my constituents that I've done something for you. And if you're doing things, if I want to change the law to fix some of these upstream things that won't maybe yield tremendous results for another, let's say 20 years, I can't really sell that to the voters. So do you know any way that somebody who is interested in that, in trying to communicate to the public, like this is actually good and we need to do this and we're not going to get quick results, but it is going to pay off in the future? Is there like a good way to message that? Or
I think just the way you said it, what I focus on now, and the reason I'm interested in the ILOS and I'm specifically interested in it around asthma is you get results quickly. And I'm more interested in persuading a lawmaker that it won't cost them a bunch of money to do this than I am them communicating that to their constituents, because their constituents probably don't know or follow that. I mean, it's too in the weeds for that. Probably not a satisfying answer, but I'm sorry. I'm focused on how do I convince a lawmaker that this is not a waste of money and would actually possibly save money and improve health outcomes in a period of time that you can get your head around. I mean, it's very hard to work at the Texas legislature, not because they're bad people. They work 140 days a year. They have their staff tend to be people mostly like right out of college. They are dealing with thousands and thousands of bills on thousands and thousands of issues. And it's just really hard.
And on that optimistic note, we're going to end things today. So please join me in thanking Ms. Marks for talking with us today.